After having heard what employers and managers need to know about the menopause at the workplace, I am pleased to introduce this other session in which we will be informed about what health professionals need to know about the issue. And for that, we will have two first-rank, very reputed speakers. Firstly, we will have Professor Margaret Rees, who is our Executive Director and a past President of the Society. But importantly, she has been the soul and the driver of this document now presented by EMAS. Then we will have Dr. Emma Persand, who is an occupational health professional working for the National Health Service. She's also the founder and the director of Lumer Health, which is a workplace well-being company. I'm sure we will have an excellent session, and I am happy to be here to listen to them. Thank you.
I'm going to be talking about what healthcare professionals need to know about menopause in the workplace. And this is based on the EMAS global recommendations published this year. The total world female population is 3.89 billion. The menopause affects all women and is a natural process. The average age of the menopause is 51. And worldwide, 657 million women are aged 45 to 59 and therefore could be experiencing menopausal symptoms. And around 50% contribute to the labour force during their menopausal years. So how do menopausal symptoms affect the ability to work? The classic symptoms are vasomotor, hot flushes and night sweats, which can lead to chronically disturbed sleep and insomnia. This in turn may lead to fatigue and irritability, difficulties with short-term memory and concentration. And this may lead to reduced ability to work, reduced working hours, and unemployment. There is a diversity of experience of menopause symptoms and the effects of ability to work. This depends on the workplace environment, physical and psychosocial. It also depends on the context of menopause, such as a premature menopause, which can occur much earlier than the average age of 51. It can occur even in teenagers. Menopause can be induced by treatments for cancer, and therefore some women with cancer will be living with a cancer diagnosis and treatment as well as menopausal symptoms. So what affects ability to work? Problematic flushes, the severity of menopausal symptoms, the higher number of symptoms, especially hot flushes, and then the working environment, such as face-to-face working, uniforms, ventilation, and access to drinking water. This is a cartoon about PPE and states that one size does not fit all, and that was putting female health staff at risk. But one also has to think about wearing PPE in the context of having severe or frequent hot flushes. It's assumed that working at home will make coping with menopausal symptoms better. However, there is no research to support this, so we have no data to support this contention. One has to remember that working from home will conflict with other tasks such as childcare and housework. On average, across the globe, women will spend 4 hours and 20 minutes per day in unpaid labour, compared to only 2 hours and 15 minutes for men. Then there are women who are in casual, informal or precarious jobs. And this type of employment may be beyond the scope of employment protections. And being a casual worker as a woman of typical menopausal age is a strong indicator of the many forms of childhood adversity which lead to difficult menopause experiences. This means that approaches to supporting women in casual work must also address the lifelong structural and systemic inequalities these women will have faced. And this review published in Maturitas this year is an excellent summary of the issues. The major concern is that menopausal symptoms, if they are severe or frequent, can lead to changes in employment status. This is a study undertaken in the UK of over 3,000 women employed at the age of 50, and the database was the UK National Child Development Study. The study found that women with severe symptoms had a higher chance of exiting employment or reducing their working hours. And this has implications to income, which is reduced in the short term, and then long-term income, such as pensions, because pension contributions will have reduced, and therefore security in later life. So, menopause affects all medical specialties, not just gynecology, and therefore needs to be taught in medical schools. So what are the opportunities for medical students? It could be a textbook chapter, a lecture during the OBGYN course, clinical learning at points of care, such as attending a specialist menopause clinic linked to the medical school, or placements in primary care. So what happens in real life? A survey was undertaken this year of the 33 UK medical schools. 32 medical schools responded, and 41% of them did not have mandatory menopause education on the curriculum. And many universities said they expected their students to gain menopause education while they were in primary care, general practice placements. So this is clearly an unsatisfactory state of affairs. How can this be improved? National societies may have training programs for both doctors and nurses, but this is after medical graduation. And there are excellent training programs organised by the British Menopause Society and the North American Menopause Society, and these integrate with national training programs. What about international societies such as EMAS? Here the aim is to improve medical education globally on menopause. So there is an online textbook, EMAS Care Online, which was last updated in 2020. There are position statements and clinical guides, webinars in schools, the monthly newsletter, and EMAS congresses such as the one that is happening now. And this material is available 24/7. There needs to be a curriculum for medical students. In 2014, EMAS wrote a position statement, Menopause for medical students, and this was published in Maturitas. The curriculum needs to cover short and long-term health issues of menopause, investigation, management, this would be diet and lifestyle, hormonal, non-hormonal strategies, the effect of menopause symptoms on the ability to work and long-term security. And an update of this statement is due in early 2022. So, what should healthcare professionals do? Healthcare professionals should recognise that menopausal symptoms can adversely affect well-being, quality of working life, the ability to work, and the desire to continue to work because of the concerns of reduction of working hours, underemployment or unemployment, and an impact on financial security in later life. Healthcare professionals should provide evidence-based advice on medical and lifestyle management of menopause symptoms using national and international guidelines. And occupational health professionals should provide advice on how to manage menopause and work, and should encourage women with troublesome symptoms to consult their usual healthcare provider to explore individual treatment options. This is especially important for women with premature menopause, so that their specific needs, such as those relating to fertility and osteoporosis, and treatment options can be addressed. Also, women living with and beyond cancer experiencing symptoms should seek specialist advice and be actively encouraged to do so, because their treatment options will depend on tumour type. Anyway, thank you for listening to this. A holistic approach is needed, and today, 7th of September, is the first World Menopause and Work Day. And the theme of a holistic approach will continue in the main body of the EMAS Congress over the next few days. Thank you for your attention.
Hello, I'm delighted to be here speaking at the EMAS Virtual Congress 2021. My name is Emma. I am Director of Lima Health, a workplace wellbeing management company, and I support organisations looking for an inclusive health and wellbeing agenda through training and education to support the diverse needs of their employees. I'm also Vice Chair of the Occupational Medicine Diversity Inclusion Task Force, and this group was set up last year after the disproportionate outcome suffered by some members of the population due to age, geographical location, socio-economic status, what type of job they were doing, etc. We work with organisations to support the health and wellbeing agenda. My background is occupational health and wellbeing. I'm a qualified nurse. I hold the Menopause certificate from the British Menopause Society and also the Cognitive Behavioural Therapy in Support of Menopause Hot Flushes certificate, also from the British Menopause Society. So the next few slides is just a very brief overview of the health and work agenda and why it's so important that healthcare professionals see work as a positive health outcome. The All Our Health framework from Public Health England and the government was a set of guidance and resources for healthcare professionals to prevent ill health, protect well-being and promote a healthy state of mind. They suggest that work is good for health and the workplace is a wider determinant of health outcomes. Employment is an important factor for health, directly and indirectly making an impact on the individual, their families and communities. Unemployment is associated with an increase of mortality and morbidity, including limited illness, cardiovascular disease, poor mental health, suicide and health damaging behaviours. Remaining or entering work is seen as a positive health outcome. There was also 4 principles set out for healthcare professionals, and this was agreed by the Academy of Medical Royal Colleges, the Royal College of Nursing, and the Allied Health Professions Federation. These 4 principles: number 1, understand the health benefits of good work and the long-term effects of avoidable health-related worklessness. Have the skill to incorporate discussions about working in the context of a health outcome. Feel supported to understand and interact with the wider health and work system of employers, occupational health, etc. And recognise their own role in supporting healthy and safe working environments, looking after their own health and well-being and those of their colleagues. It also recognises that work can be bad for our health. A bad working environment characterised by low levels of job control and organisational fairness and a high effort reward imbalance may contribute to poor health. Work-related stress can be caused by poor work organisation, the way we design jobs and work systems and the way we manage them, by poor work design, lack of control, poor management and unsatisfactory working conditions, and again, lack of support from colleagues and supervisors. However, there are substantial differences between working men and women, and one of the differences is reproductive health. Reproductive health is the silent burden that women carry because working practices, policies, procedures, colleagues and supervisors, healthcare professionals are not equipped to have a reproductive health conversation. So we're going to look at women at work. So I come from a biological, psychological, social and cultural model. And we'll look at reproductive health, which incorporates some of these things: pregnancy, menopause, endometriosis, polycystic ovary syndrome, PMDD, infertility, and the 5 gynecological cancers. And I say these words because these words are not spoken within a work context. A woman suffering any of those conditions will suffer them in silence. I've put pregnancy and menopause in italics because obviously they are not health conditions, they're not illnesses, they are a natural state of a woman's reproductive health. Pregnancy, some women will experience a pregnancy, but all women go through the menopause, and that's why we're here today to talk about it. The psychological aspects of a menopause: brain fog, fatigue, lack of concentration, lack of recall. They're some of the psychological symptoms that women report, but also the attitudes and beliefs of women. how they feel about aging, how they feel about their period stopping, some women may rejoice in that, some women may not. Some women see that it's a mark of a new era in their lives. Other women will see it as aging and become irrelevant. This all can affect the mental health. And like I said, stress before, work-related stress, continuing statistics from the Labour Force Survey state that women between the ages of 45 to 55 report the highest incidences of work-related stress. Now, the symptoms of stress or psychological concerns or issues can be symptoms of brain fog, lack of concentration, feeling overwhelmed, and women and healthcare practitioners are more likely to attribute some of those psychological issues to work-related stress or general stress rather than perimenopausal symptoms. Social and work attitudes and beliefs in the workplace can contribute to how a woman experiences a menopause transition. Care burden, unpaid and informal work. COVID-19 has shone a spotlight on that. The inequalities and disproportionate care burden that the women took on, the education for children, the furloughing, all contributed to the situation we are now with women. I'll look at that in a report later on. The type of employment for men and women are different. Women are more likely to be part-time, but if they're in their career, they still have the care burden, 30% more of domestic duties, etc., etc. And today we're talking about the culture and ethnicity, culture that it can impact menopause transition. You may be aware of different cultures experience menopause in a different way. In Japan, hot flushes are not one of the key symptoms that the women report. Women report more of aches and pains in their shoulders. Japan have a different diet and also a different way of viewing menopause transition. Women of Indian origin in Britain report hot flushes as one of the main symptoms, but women of India do not report symptoms of hot flush in the same way. So the culture can impact how we view and how we experience a menopause. The disproportionate outcomes for women due to ethnicity. If you look at Black women in healthcare, they have a disproportionate terrible health outcome. They're up to 4 more times likely to die in childbirth, and they're more likely to experience a stillbirth. Structural and perceived prejudice for trans women, for Black women, for ethnic diverse women, all contribute to a reproductive health experience. And so when you are looking at a woman, or you have a woman in your clinic, or it's one of your patients, to look at her as a biological, psychological, social and cultural aspect of it will be taking the whole woman into consideration, not just the condition you're seeing in front of her. So this is what women said. So I've got lots of research. We all know lots of reports of what you should and shouldn't do, but this is from the actual mouths of women. It was a survey from Public Health England in 2018, and over 7,000 women responded. The hidden burden of reproductive health was particularly evident in the workplace, that symptoms often affect women's ability to carry out daily activities, but many conceal their symptoms from work colleagues. 31% had experienced severe reproductive health symptoms in the last 12 months, ranging from heavy menstrual bleeding to menopause, incontinence to infertility. 12% of women had taken a day off from work due to menopause symptoms, and 59% had lied to their boss about the reasons for their absence. 35% of women had experienced heavy menstrual bleeding, which previous evidence shows is associated with a higher unemployment or absence from work. Stigma, or the cultural stigma surrounding reproductive health, was a key concern for women taking part in the survey, with less than half of women seeking help for their symptoms, regardless of severity. This is a well-known report. I'm sure it'll be spoken about a few times during the Congress. The effects of menopause transition on women's economic participation in the UK in 2017. Now, I think the results may be slightly changed now. Since 2017, we have seen a rise in profile of menopause. More and more people are speaking about it, normalising the conversation, the reproductive health conversation. But at the time, it found that 25% of women going through a menopause transition will have symptoms that will significantly affect their health and well-being. And if you think back to 59% of women didn't tell their boss why they had a day off. Less than 20% respondents said their workplace provided information about menopause. 3 out of 4 women will experience hot flushes. 50% of women said work was more challenging, and 47% of this report did not tell their manager why they had a day off. The top 6 symptoms: fatigue, hot flushes, difficulty concentrating, anxiety, worry, insomnia, problems with recall. Top factors influencing this was high temperature, poor ventilation and humidity, no access to quiet area space, lack of light and noise issues. 77% wanted more information about menopause at work. The workplace can support or make things worse. Now, that was an important finding, because if the workplace can make things worse, then there is a duty of care to reduce the hazards, which is the workplace, through risk assessment, and put controls in place to support that woman in the workplace. The barriers and challenges for all of us, for healthcare practitioners. So the workplace supports an employee as a worker, as a gender neutral worker, so somebody who doesn't have reproductive health. There is lack of awareness, education and training support, not only in healthcare professionals training, but for women, they're not trained, and for workplaces, they're not trained on reproductive health issues. There's a workplace imbalance of representation. There is a segregation. There's a segregation within occupations. Women are more likely to be in the health and social care. Men are more likely to be in the construction industry. Also, there's a vertical segregation where men are more likely to be in the positions of power, of decision, of influence, the ones who write the policies. And women's role as creators, nurturers, educators and carers are rarely taken into consideration when judging a woman's performance in the workforce. These all lead to inequality of outcomes. We know that more women are more likely to die of a heart attack than men. Women are 50% likely to have an osteoporotic fracture. Men are 20% likely. Women are more likely to be admitted to a nursing home due to incontinence issues. And these are health inequalities that can be reduced through education, self-management, therapeutic interventions. These are some of the reports I've put on here for your further reading. The lessons learned where women stand at the start of 2021 looks at what happened to COVID during the time of COVID and what happened to women's health and women's career. The annual report from the Chief Medical Officer at the time in 2014, Dame Sally Davis, the health of the 51% women, and Better for Women, improving the health and well-being of girls and women from the Royal College of Obstetricians and Gynecologists. Basically, an overview of all the reports find that women are struggling to get the right information about their health and to book routine appointments. Health services miss opportunities to ask the right questions, prevent illness and ensure the best outcomes for girls and women. It recommends that all healthcare professionals need to be skilled and equipped to discuss reproductive and sexual health within the context of their work and patients' overall needs. And it recognises that women would like reproductive health issues to be normalised so that they can be discussed openly and self-managed wherever possible. It emphasises the need for more strategy and support in the workplace around these issues. So what we're actually looking at is a gender-sensitive assessment. Previously, before, it was gender-neutral. So you're moving from a gender neutral to a gender sensitive assessment using gender mainstream strategies. Now, this is a very, very brief overview of an occupational health and safety strategy from Europe. So gender neutral is the approach where the average male worker or body is taken as the standard. So all policies, procedures are designed around that. So they wouldn't have reproductive health issues or the care burden or the informal work or the education burden that women take on as standard. So gender neutral plays a part in what we're educated on, what healthcare professionals are educated on their modules and their curriculum. So we're looking to going towards a gender sensitive approach, which takes on the different working and social situations of women and men, as well as gender relations into account. So it looks at the cultural aspect as well of being a woman. And gender mainstreaming, all it is, it considers the differences between the conditions, situations, and needs of men and women. It is used to integrate concerns of women as well as men into education, policies, and actions so that equity can be achieved. So how do healthcare professionals do it? So in my line of work, we like tools in occupational health. We like tools, we like to signpost, we like to use clinical evidence to signpost. And there's the menopause rating scale that I use. It is designed, it's simple design for the women to fill in themselves and take it to their GP or take it to their specialist. It's a scoring system, very quick to use, whereas a GP will have roughly 10 minutes to identify, exclude what it isn't and find out what it is. It helps the GP and the woman open up the conversation and focus on the symptoms that impact her life the most. We're talking about quality of life. There is the green climateric scale that's I've taken from the wonderful Menopause Matter website. Equally, it's the same thing. And there's also the Menopause Quick 6 scale. That's a Canadian scale, and it was established in the same vein as what I'm talking about here, that there was a unique opportunity for healthcare professionals to introduce the reproductive health conversation in all clinical settings. And so it's 6 questions that they ask all perimenopausal age women to identify if there is any need to signpost on for further information or self-strategies to improve the quality of life. So the Keep Women in Work strategy, like I've said before, an opportunity exists to reduce health inequalities just by simple questions to signpost a woman, to help her find out for herself, to educate herself on her options to going forward. Healthcare practitioners should know the red flags. You should know that a woman, if she is not exercising, or if she's smoking, or if she's not got the right diet, it will not only influence her overall physical health, it may impact her reproductive health as well. Intervention and signpost on for further support. Taking a biological, psychological, social with a cultural approach to women's health that considers the impact of intersectionality. Know that it's not an equal playing field for all women, and some women have more oppression than others and will need additional support. Mental health, stress, and physical health are inextricably linked. There is not a time like there is today for a woman. With all the burden, the childcare, the elder care, working, we took on the education role for COVID. There isn't a time, and there will be stress. There will be some psychological distress coming out of COVID and people in the workforce. So thank you for your time. I hope that I've given you a brief overview of menopause in the workplace and what we need to do as healthcare professionals to start addressing the inequalities. Thank you.
Okay, thank you to Margaret and Emma. And now we have time for questions. We've got 2 excellent presentations. Probably I would like to stress again that today is the first time in which we will have a World Day dedicated to menopause at work. And this is something that we will stress to repeat every year, just to establish this date as important for that matter. So now we have questions. We have a first question, as I said, now it's from Professor Rees. It's a question for Emma. How would you structure a virtual consultation? This is a very important question that probably will need to be addressed, because you know that now the great help of new technologies, and this Congress is a proof of that, an example. So Emma, what would you comment about that, please?
So structure a virtual health consultation, is that correct?
Yeah.
Yeah, so all of us, when our work changed overnight during COVID, we had to quickly learn new skills ourselves, become more virtual and technologically aware. And unfortunately, I have learned through mistakes. I have better improved my practice through mistakes. And the structured, the virtual assessment, you need to manage expectations prior to it. So it isn't the same as face-to-face. So virtual consultations, so it is the same 30 minutes, 40 minutes going through a biological, psychological, social and cultural experience, the same questionnaires. However, you have to be aware that you probably need to signpost very quickly, or I always ask if there's somebody there with them, or because for one example, a woman triggered when we were speaking. Now, if you're in face-to-face, you can deal with that, but remotely, I felt very helpless for her. And so that session took a longer time of me trying to address and get support for her. So I now always manage expectations beforehand, and we talk about not who a GP is, where she can go afterwards, who's there to support her. So that's one aspect. The other one is obviously confidentiality. So that's managing expectations as well, because you don't know who's in the room with her. Has she got access to a quiet space? Who's overhearing? And also for yourself, a virtual, you need to make sure that you're GDPR compliant in what you're using, how you're retaining and storing and processing that information. So a lot of it for me, the structure was managing it beforehand and changing my practice, but actually in the assessment with the woman remained the same.
Can I continue?
Thank you. Yeah, of course.
Okay, can I continue? So what happens with a general practitioner, family doctor, who's only got 10 minutes?
So if a family doctor's only got 10 minutes, the woman, I talk to the woman about arming herself with as much information as she can to support the GP in their practice. So it's in the UK, it's looking at the NICE guidelines and knowing what treatments options are available prior to you going to your GP. Using the menopause rating score prior to it, so you identify basically your top 5 symptoms, because if you think of how many symptoms that can be, and if you want to identify the top 5 that you would like to address, and taking a diary, a history, so empowering the woman with a bit of knowledge about her health, what may be going on, because remember, we have to exclude what it isn't first. That will enable that GP to have 10 minutes of that's eliminated the GP having to do that investigation beforehand, and opens up the conversation. And obviously a menopause transition conversation, or perimenopausal symptoms, will take more than one 10-minute consultation.
Okay, thank you. If I understand well both the two presentations, I think that what it is needed is a huge effort to increase the sensitivity to the gender issues. This is something that I think is quite clear. And now, obviously, there is a role for everybody, including societies, including organizations like, for example, universities and so on. Margaret, for example, was speaking about the curricula of the UK universities, in which there was only a small part dedicated to menopause, if any, because that was not common in all the universities. So my first point concerns to Margaret, and is how do you think that scientific societies, and I am thinking of EMAS, obviously, because it is now our Congress, but obviously all the others, big societies dedicated to menopause, might do something to help universities to increase their dedication in the curricula to the menopause issue. For example, I am thinking of the possibility of introducing courses or masters or whatever dedicated to the menopause, in which the societies, the scientific societies, might have a role, an important role in the participation. What do you think of that?
I think we start off with guidelines, and what I'm working on is the essential global curriculum about menopause for medical students worldwide. So it's assessment, the implications of menopause, screening tests and management, and also putting in the fact that menopause is not just hot flushes and long-term health consequences such as osteoporosis, but it does affect daily living and employment, to put it in a whole context. So this is what will be launched hopefully in early 2022. And then this could be then carried on with webinars and other educational materials. And I think the secret is communication and education.
Yeah, I totally agree with you. And I'm thinking that maybe there might be something that we might do also with health professionals, not only with the students, but also with our colleagues working beside us in hospitals or in centers of clinical care or whatever. So my point is, I have 2 points actually. One for Emma, because you presented data about, for example, the surveys that you conducted with women. You presented one survey which was answered by some 7,000 women, if I am right. But do we have information about the health professionals themselves? That's the first question. And then for Margaret, if you see something that might be translated in terms of education, for example, for our colleagues, in terms of increasing, with the purpose of increasing the sensitivity to the gender issues in general, and obviously to menopause. So, Emma?
Yes, I was just going to see if I could get the research up. So last year, the results were presented last year. It was, I think it was 2019, they did the BMA did a survey, British Medical Association, of their doctors and menopause attitudes. And the report is, it's similar to the reports that I put up on here. Doctors reported women who were experiencing menopause transition had reported that they were struggling, that they had considered not leaving the workforce, because of course women have to work as well for they haven't got the luxury of giving up work completely, but altering their career to support their symptoms. And a large proportion felt that their colleagues and peers were not supportive, that that menopause was still a taboo issue within the medical profession, and they couldn't speak about it, and they were reluctant to speak to their line manager. I'll find it for you.
Margaret, how do you see the answer to this need to increase the sensitivity of our peers in what refers to the menopause issue? You think that still with them there is that feeling of the negative feeling of menopause, which might be something that women would like to hide or would like to not to speak of, because it's I wouldn't say a respective issue, but something related, something which is negative, because still in our culture, you know that the loss of fertility is something that is considered a negative fact of related with menopause, and also aging, which is something important in our society, because you know that we are a society in which we consider the youth as the ideal state. So you think that with our colleagues still those ideas are still in their minds and condition their attitude to menopause?
I think the problem is that, as you put it, menopause equates aging and loss of status. But in some countries and some cultures, being menopausal is a positive thing, because there is no need for contraception and no need with the burden of the risk of future childbearing, which may be unwelcome. But if you look at menopause curricula, and what is taught in medical schools, menopause is actually a very small part of the agenda. When I was in Oxford, it was one lecture, and then the students came to the clinic, but not all students came to the clinic. They weren't obliged to. So there's also been the risk of treatments for menopause, which has influenced how often it's taught. Because with the Women's Health Initiative, which was first published in about 20 years ago, it was considered that HRT was dangerous, and a lot of doctors refused to prescribe it or even undertake any menopause consultations anymore. And this had a severe effect on the level of teaching in medical schools. So it is multifactorial. And we're only climbing out of the results of the initial results of the Women's Health Initiative now, where long-term studies show safety rather than adverse effects.
I have to agree with all that, with it, because we look at menopause as an aging process rather than just a stage in life and health. Culturally, it impacts women. And so instead of it being a biological model that we all use, if we look at a holistic view that Margaret put up and I put up earlier, that's one way of going forward. So even if a woman does not have symptoms that impact her, she will still have health inequalities due to fluctuation of estrogen, and she's not aware of those because there's no education around them. And also she may have some psychological issues because of how she perceives herself in a Western society where we don't value an aging a woman going through midlife. And so it's looking at it the whole perspective. And I think you said something, Margaret, that really resonated with me, that healthcare professionals need not to just look at their discipline they're the expert in. They have to look at the patient and the whole and what stage the woman's at, because that will dictate how they treat that woman. So it was the British Menopause Conference when we were allowed to go face to face. It was the last one, and it was a HIV specialist that was coming across a demographic of patients that she hadn't treated before. It was menopausal age women with HIV, and she was having to learn about menopause in order to support treatment of HIV. And I think that should be in every discipline.
Yeah, totally agree. And my view is that perhaps this limitation in the dedication and the curricula of our universities to menopause is because probably we have considered only the biological aspect of menopause and what is related with menopausal hormone therapy, for example, and so on. Obviously, this is an area which has grown a lot in what refers to impacts at other levels of the body, as the bone or the cardiovascular organs and so on. That's true. But probably, and I think this today is an example, probably we need to look at menopause as something with a wider scope. And thinking not only in the biological aspect, but obviously, well, we have now commented in your presentations about the psychological issues, for example, or about the sexual issues. Is something that today we will have another session dedicated to women living beyond cancer. And the one big issue is the sexual impact of the cancer treatment and the impact of the menopause, the drastic level of hypoestrogenism that these women are forced to as a consequence of the adjuvant treatments, for example, the aromatase inhibitors. So perhaps what we need is just to think of interdisciplinary approaches to the menopause. What do you think of that, Margaret?
this is music to my ears. When I was in Oxford, I had multidisciplinary clinics. So there was the standard menopause clinic, and then there was the joint with other specialists, early menopause with endocrinologists, cancer clinics with breast cancer specialists, and gynecological cancer specialists. Then I did a specialist osteoporosis clinic, and I used to do it both in Oxford and in another hospital. So any difficult cases were accumulated. And then we had the hormone migraine clinic. So it was 2 neurologists and me looking at hormonally triggered migraine and headaches. And we had a catchment area, basically the whole of the south of England. And this model worked because it was flexible and it allowed teaching in other disciplines. And people who would not have thought about hormonally triggered issues then started thinking about them. So I think the model is not just a menopause clinic with gynecologists, it's a menopause clinic with other disciplines.
Yeah, I completely agree again.
So,
I have the cognitive behavioural therapy certificate for managing hot flushes and night sweats, and that looks at the whole aspect of it, the psychological symptoms, and it's for women have gone through breast cancer that are unable to take HRT, and it's for women who don't want to take HRT, or it's women taking HRT and also needs some further support, some lifestyle strategies. It's a therapeutic intervention. And I also signpost to other healthcare disciplines that can support them. So occupational health therapists, occupational health professionals that can support them going back to work after breast cancer, because obviously they'll have menopause symptoms as well as coping with what they've just gone through. Women's health physiotherapists that can help with the incontinence issues to prevent incontinence, so it reduces them going into a nursing home later on, and they still maintain their running or their exercising because they're not conscious about incontinence. So it's looking at the whole aspect and linking in with all the disciplines that can support that woman.
I totally agree with you. Another point is, and that's for you, Emma, that's the figure of the occupational health professional. Well, you dedicate your life to that, and obviously you are very much involved. But you know that in many countries this figure does not exist. So could you figure out any approach to extend this figure to other countries? Because obviously, if women have to improve the conditions of their workplace, obviously they need some advocacy, somebody pushing to increase the quality of those conditions. I'm thinking that from what I know, in some countries, it is even the trade unions, those in charge of improving the conditions in the different organizations, obviously also in hospitals. I'm thinking of hospitals because, in fact, our session is dedicated to healthcare professionals. So could you perhaps comment a little bit about that?
So if you don't have occupational health or that model, then it will be going back to what Margaret says. I suggest that the training, the curriculum brings in a cultural aspect of, so it's not just menopause, it would be all of it, wouldn't it? Endometriosis, polycystic, any reproductive health. So the training would cover the life course of a woman to enable the healthcare professional to have a broader experience and to advise and to link in with the healthcare professional that is discharging the woman back into the workplace. So whether it's an oncologist, if you don't have it, or whoever, that they would have that training initially that on what impacts the woman. Or we roll out occupational health around the world.
I'm sure something has to be done about that, obviously. And this is one of the many ways that we are challenged to follow in order to improve these conditions. You mentioned, Emma, one particular case, which is the transgender women. And this is something which is also increasing in our society. And do you think we need specific approaches in those cases?
This is a new area to me. I'm gathering as much information as I can. I was speaking to a trans woman, and she suffered from hot flushes. So apologise, my phone's going there. She suffered with hot flushes, and she was GP was managing her. We were talking together what specific healthcare, inclusive healthcare would be available to her and her trans community. There's also trans men that will still have reproductive cycles, that then may not want to go to what are perceived as women-only clinics. So it, again, changing the conversation and the narrative of menopause being an age-related middle-aged woman disease model that we have to a life stage that a lot of people will experience. It's normalizing and changing the narrative. And as we go on, and as trans is raising its profile quite rightly, that so we get equality across the board, I think more and more focus will be on this area and hopefully more training.
Thank you. It's something that certainly we will need to pay attention in future, in the close future, because this is an area which is growing and getting very much social impact. Yeah, Margaret, you have a great experience, a huge experience in scientific societies, in EMAS, obviously. You are the executive director, you have been the president of EMAS. You think that we in EMAS could do something in collaboration with the affiliated societies to improve the word and to spread the word and to improve the conditions of women across the world?
Absolutely. Anyway, we could start by translating our global recommendations. Just having this workshop this morning, which is translated in many languages, is a first step, because it is much easier to listen to people who are at the cold face and hear it in your language than reading the written word.
Mm-hmm. Yeah, certainly. And do you think there is any other, just not looking backwards, but in front to more institutions like, for example, the WHO, which is enormous and huge? You think that we could do something?
Absolutely. At the moment, they are really stuck with dealing with COVID as their priority, but this is part of the long-term strategy. And this is why we had many affiliated societies and organizations outside medicine as well as inside medicine endorsing the statement.
Okay, I'm receiving messages that we are out of time. So just to thank you, the speakers, for the excellent talks, and also for the debate, which has been very profitable and very interesting. Thanks a lot. Thanks to the audience. And we will continue, just to remind the audience that this video will be available for 1 year at the EMAS website. So thanks, and please go on with the Congress.